Welcome back, everyone. It is my honor to introduce our next speaker, Dr. Paul Pepe. Dr. Pepe is board certified in internal medicine, pulmonary medicine, emergency medicine, and EMS. He's a master of both American College of Physicians and American College of Critical Care. He's recognized for practice-changing research and numerous over 500 publications in multidisciplinary landmark papers, especially those revolving around resuscitation and pre-hospital care. He has received numerous global honors, including the Society of Academic Emergency Medicine Silver Anniversary Excellence in Research Award for Lifetime Scientific Achievements. Today, he's going to talk to us about what's high-performance ventilation, the physiologic approach to quality ventilation. Dr. Pepe, welcome, and I'm excited to hear what you're going to teach us today.
Okay, can you hear me okay? Great, okay, thank you so much. So, anyways, it actually is my privilege to be here today and, to speak here. The educational, let's say, offerings that have been provided by the University of Maryland and particularly the Department of Emergency Medicine have been fantastic and just things that I've always followed. And so this is, I'm just glad to be part of this. So anyways, specifically, I wanted to thank the program committee for getting me involved here today. They could have had other choices. Then I found out later there's a certain, it's like an affirmative action clause in the bylaws there that for their CME department, that you have for every attractive, charismatic speaker that you have, you've got to have certain people who are, let's say just aesthetically challenged person. So I got to be that person for you today, and I'm here to make the other speakers look good. So we'll see how that goes. Before I get started, of course, we're always asked the following things. What are the four inevitabilities of life? Everybody always knows the death and taxes part. And of course, in California, it's kale. But also for me, there's disclosures as well. And so the only disclosure I have is I'm not a morning person. I hope to be awake by the time I finish my talk. Okay. And also in some circles, I'm considered, let's say, a non-essential personnel. And more importantly, and in fact, in the scientific community, if you can see my shirt here, I am insignificant. So as it goes. But one thing I do want to say is that my background is I think important to note here in terms of my background in respiratory and critical care. So actually, I was trained originally back in the 70s in Seattle to look at that particular area that we're talking about today. And did a lot of work in the laboratory, clinically, prospective trials, et cetera. And it was a real privilege, and it really helped me. In fact, one of the things what happened for me was they asked me to take some of the things we were doing in the ICU to the streets in Seattle. And that afforded us some really good outcomes because I think we were doing this well. In fact, one of the disclosures I should have made that this talk I'm giving, a lot of the slides you'll see are things I was giving in the 1970s and 80s. These are actually the same slides from then. So it's kind of good to have the oldies but goodies. So some of the things that you may know about that I've done that came up with over the years were things like the auto PEEP effect and looking at reappraising how we were delivering mouth to mouth and so on during CPR. And then more recently, the detrimental effects of breathing in hemorrhagic states, for example, and a few other things that you'll see as we get through here today. So that's a little bit of my background, and we're continuing to do that. And some of the things we're going to talk about today are various studies that we've done in the laboratory currently to look at the effect of ventilation on CPR and as part of it. And the question I said, we've always had this focus on quality CPR, right? And the question I'm going to say is that, what about the quality of ventilation? So there are multiple factors that people will tell you that constitute quality CPR. What are they? Well, like in this canonical plot that we did contour plot that we did a couple of years ago, showed that we look at rate versus depth, et cetera. That there are those components, rate and depth, and remember interruption of the CPR. How about recoil? I could go on and on. It turns out there's 6, 7 things that define what quality CPR is done. And that's always been a big focus of ours over the years as well. I'm going to say that one of the factors that affects quality of CPR, of course, is actually the quality of ventilation. And more importantly, as we're going to get through here, is that the quality of ventilation is going to affect the quality of CPR in ways that you may not even know about. And that's part of the reason why we're here talking about this today. So the first question I would have is that, what about quality of ventilation? Well, the first question is, why do we ventilate? Okay. So if we're going to talk about quality of ventilation, why do we ventilate? And you're going to hear from me, because I'm a pulmonary physiologist in a sense, is that when people use the words like hyperventilation, they're meaning breathing fast. And people can be tachypnic and yet be hypoventilating, like whom? Like a COPD, for example, right? So, but why do we ventilate? And for me, there's a difference between ventilation and oxygenation. When I ask the question, why do we ventilate? Most people will say, oh, to oxygenate the patient. But oxygenating tissues versus oxygenating the blood versus whatever. But I'm going to tell you that there is a difference from a physiological point of view between oxygenation and ventilation. Now, they're obviously intertwined, but there are differences there. Okay. For example, saturating red cells is what I'm thinking about when I'm going to talk about pulmonary oxygenation, not tissue oxygenation right now. So saturating red cells versus clearing carbon dioxide. From my point of view, when we talk about the definition of hyperventilation would be low carbon dioxide level. Hypoventilation would be, high carbon dioxide levels. So we have that. As I get through this, you're going to see me talk about oxygenation versus ventilation. Let me point out why. So this is actually a slide I think I used in the 1970s once. And so please bear with me though. And what this shows is that over here, we've got the red cells returning to the lungs, and I give you two different sections of the lung. One is where carbon dioxide can go out pretty easily, and you can clear it pretty quickly in this area. That's why we have people with, you'll see later, I'll have people with pneumonias breathing at 10 per minute, but they'll be desaturated significantly. They can clear the CO2, but they cannot, they're not oxygenating the lungs. And the reason why is that other areas of the lungs, and there's a lot, let's say a pneumonia, whatever, this is atelectasis here, is that these areas will never get oxygenated. And there's a lot of them, then you got some troubles, okay? And here's what this arrow is saying is that no matter what you do here, this is not going to get fixed by putting more oxygen in there, like 100%. It's not going to get fixed by breathing faster here. What's going to fix it is reinflating this area. So my point here is what? Faster rate or supplemental oxygen will not help deflated lung zones. You need adequate lung inflation for better oxygenation. And in CPR conditions, you need it for better transpulmonary blood flow during chest compressions. We actually see in the laboratory, if we're not using an adequate enough lung inflation, that we start getting pulmonary vascular resistance. So that means we can't get blood, we're not getting blood through the lungs because those areas are closed off. So we have to make sure that most people don't appreciate the fact that during CPR, not only do you have to inflate the lungs for oxygenation purposes, but you got to inflate the lungs well enough to get blood through them. And it's always been bewildering to me sometimes, but when I've seen the least, I guess, more recent approaches where people want to use smaller tidal volumes, which means they don't really understand the mechanics here. So let's talk about that. What's an adequate tidal volume? And the answer may not be perfect in the end, but I'm going to give you a better feel for it, that it's better be larger than most people are thinking nowadays. And I'm going to tell you why, because the main culprit, as we all have begun to learn, I've been so appreciative of end-tidal CO2s because it helped people understand what was happening here, is that one of the things that we learn is that we got to not only get better lung inflation, but we've got to get better blood through the lungs. So let's talk about that, especially during CPR conditions where we're constantly pressing on the lungs, and so we're deflating them even more so than we would in normal life, so to speak. So normal breathing, you're generating negative intrathoracic pressure. Here's your diaphragms. What are they? They're dome-shaped muscles, and when they contract, they pull down, and they pull the lungs down in a very specific architecture, sort of like a syringe, and you're pulling air into the lungs. Now, that negative intrathoracic pressure acts like a sucking vacuum. In contrast, when you're giving a positive pressure breath, you're pushing the lungs open, and that inhibits venous return. It increases intracranial pressure, et cetera, let alone intrathoracic pressure. So when you take a normal breath, you're pulling the lungs open in a very specific architecture, mostly at the diaphragms. Right now, as you're all breathing, I probably can't even see you breathing in a sense, but you're doing it quietly. Most of that, 80%, is done with your diaphragms, pulling the lungs down in a very specific architecture. And those are dependent lung zones that are dependent on those lung zones being opened by our normal breathing patterns. However, when you're trying to breathe for someone and push those lungs open, it's not so easy to do that. So usually when you and I are breathing, we're using about 5 to 7 mils per kilogram. But then your lungs are kind of slowly deflating themselves. And so as a result, we've all physiologically, we take sighs or yawns to re-recruit gradually deflating dependent lung zones. So the 5 to 7 we learned early on was that if you gave a little bit more than that, you could avoid having to physically give yawns. But the other problem is that when you give a breath, you're maldistributing because the lungs don't want to get pushed open, okay? So here's what I mean. So positive pressure ventilation, rescue breaths generate this positive IT, it pushes the lungs open, but it's harder to push those diaphragms down and so on, and things will maldistribute into different areas. When you have the positive pressure breath and pushing it, you're also diminishing venous return, resulting in cardiac preload. Most of you know this now, thank you. And that's been very rewarding to see that appreciation occur in the last 10 to 15 years. But also when we're pushing the lungs open, it does so in a maldistributed manner in areas of less resistance, not the diaphragm as usual. So the normal tidal volume does not open the normal dependent lung zones, and that's a problem. It also increases intracranial pressure while we're in there, and that worsens the chest compression effects, so you can't get blood, compromises the cerebral blood flow, and you need to develop, therefore, my point is that we need to develop a ventilatory strategy to diminish mean intrathoracic pressure, meaning the average intrathoracic pressure throughout the cycle by lessening the need for positive pressure ventilation. So I'm going to talk about how can you give more efficient breathing. Well, by the way, most people probably doesn't even know what a Pendeloff effect is, and so just to get you become a little acquainted, one of our things that we talk about in pulmonary physiology is defined as the displacement of gas from a more recruited non-dependent lung region to a less recruited dependent lung zone, and this phenomenon may cause lung injury, and that causes injuries particularly with people like ARDS, etc. We can talk about that later, but that's a different lung disease than the lung disease of not breathing. And as we go through here, so here's my point: is that a larger tidal volume, and by the way, the Arts Nest study that actually showed that a larger tidal volume was harmful is actually accurate. You had heterogeneous lung disease. You had areas that are normal, and if they're overstretched with PEEP on board and then a larger tidal volume, you can cause more barotrauma under those circumstances. But here in the average cardiac arrest patient, we're not talking about that kind of lung disease. We're talking about one of deflation. So let's do the kind of thing where I can compare a larger versus quote unquote smaller tidal volume. I'm just going to use things that are easy math to do here. It's not what I'm recommending. So if you want to achieve a minute ventilation of 5 liters, you could give it either as 500 times 10 breaths per minute, or you can give it as 1,000 times 5, right? They're both the same, 5 liters per minute. But the question is how much of that gets into the alveoli, okay? Consider tidal volume minus the dead space in terms of alveolar ventilation. In other words, how much CO2 we're removing is going to depend on how much dead space is part of that breath, okay? So if you look at 500 minus 150, that gives you about 3,500 mils as alveolar ventilation in terms of what you're clearing CO2 with. If you did 1,000 minus 150, what do we get? 850 times size, 4,200. You can see it's a much more efficient breath in terms of alveolar ventilation. In fact, if you gave that times 4, it gives you essentially the same. You're actually doing, with the larger breath, you're getting a more efficient breath. You give less breaths, and therefore, during that period of time, you have less positive pressure breaths going into the lungs. Now, this is not what I'm recommending. I'm just giving you a concept of why a larger breath is more efficient, and I can get away with lower number of frequency of respirations. So larger breath is more efficient ventilation-wise, okay? So larger breath not only oxygenate better because you're pushing more dependent lung zones open, okay? But there is better CPR because you actually have better transpulmonary flow, and there's more preload, allows more transpulmonary blood flow because there's less intrathoracic pressure over the minute, and it ventilates better. It removes CO2 more efficiently, as we sort of just explained, in terms of alveolar ventilation. And also, here's the irony is that you have a larger chest wall expansion, you eject the air more forcefully. So the people who first came up with mouth to mouth and so on were actually demonstrating this years ago, and which is kind of interesting because you use the actually expanded chest wall to help recoil things a little bit faster. So this lowers mean intrathoracic pressure, because that's what we're trying to get at here, is the lower mean intrathoracic pressure, giving fewer breaths over a minute, and those that are ejected faster. Okay, so that's better flow, fewer intracranial pressure increases during compression, so you get more blood through there, not having that impairment of a higher intracranial pressure, and there's more appropriate lung inflation and CO2 removal. Okay, so point is that I tend to go with a larger adequate lung inflation. Now, what is that? What's an adequate volume to choose then? So one could argue that 8 to 10 is actually fairly safe if you're intubated, there's no PEEP on board, and no diffuse lung injury, okay? And that's the majority of cases, we hope, at least in the ones that I take care of where I work. Now, if you have an unprotected airway, that's a problem. And especially if you give it too fast, it's more apt to go into the stomach. It's more apt to maldistribute. And so part of it is how you deliver the breath, particularly if it's intubated or you at least have a supraglottic airway. If you press too fast, too hard, then what's going to happen is that it's going to displace in the wrong places, especially with the supraglottic, and even inside the lung, it'll maldistribute. So more. So we tend to give a steady squeeze over a second or 2 seconds or so, but with a quick release. Studies that were done a few years ago, it was interesting. They told people to slow down on their breathing rates, and they came back and they specifically taught them how to do it. And what happens, they slowed down, but then held the breath in. So part of what we have to do is make sure there is a steady squeeze with a quick release to let that air out and recoil as fast as it can. So we're not measuring tidal volumes, but I would say at least get a good pronounced chest wall rise, but with a steady squeeze and a quick release. That's essentially what we want to do, is get the chest wall to rise. And that's how we always kind of taught that in the early days, but we've lost that in terms of people thinking about hyperventilation, but not knowing what hyperventilation meant. So are you paying attention to release time is an important one, let alone, the inspiratory time, et cetera. Release quickly, don't prolong the positive pressure time. And that's part of things that I don't know we are teaching on a regular basis. At least in places where I've gone, I've seen that these kinds of things are not being paid attention to. And I'm out on the streets regularly watching what's going on. All right, so the first part here is to say, first, pick an adequate tidal volume and appropriate delivery and release time. And I gave you some indication about what that is, okay? Now, the next question is, how often do we breathe them? And for me, that's pretty easy, and particularly nowadays, because one of the things I've been able to add into this talk is that we have end-tidal CO2. So I'll give you a couple examples when we get to that. So ventilation for me is clearing CO2. The need to ventilate is basically dependent on CO2 production, right? So again, ventilation is tidal volume times respiratory rate. We've already talked about getting an adequate tidal volume. And so after that, the question is, since we've already chosen adequate tidal volume, then I move on and say, how fast should we breathe the cardiac rate? What is the frequency of breathing? Okay. So the need to ventilate, of course, is CO2 production and venous return. Those are all the things that if there's good oxygen consumption and good venous return, you're doing well. And especially if you're exercising, this is all revved up and you're going to need to breathe more, et cetera. But in the cases that we are dealing with, ventilation should match perfusion. And in this case, you're not doing that much CO2 production. In fact, in cardiac arrest, there's little oxygen delivery and consumption. Everybody knows this. This is all you guys all get this now. Little CO2 production and venous return, and little need to ventilate. Now, one of the things that can change, of course, is that if you now get better flows or you get ROSC, return of spontaneous circulation, then you need to enhance your, match. Ventilation needs to match it, and you need to get that up. Now, this is actually a study I did in the 1970s. We published it finally in 1985 when I got around to it because I was changing jobs. But, if you look at CO2 production, it's really less than half of normal. It's pretty low. In fact, typical CPR only delivers what, 20%, 15 to 20% normal blood flow if it's done optimally and early. And then, of course, it loses its ability to work well over periods of time. But, so your typical CO2 production is extremely low. Now, if you do things like we're doing today, where we're giving things like the lowering intracranial pressure and getting better blood flow through the lungs with things like the typical head up zone, where we do the ITD, ACD, and head up, you're getting almost normalized blood flow. And then the typical ROSC zone, you're getting pretty good oxygen delivery during those periods of time. So my point is that if you're in a cardiac arrest state early on, you may not have to breathe as much, but as you get more blood flow, you may have to breathe more. And so that's why you always look at this as the conventional CPR versus an ATD, ITD head up, or ROSC, the little pony and versus the big horse there. So dynamic determination, better flow can change the indication of the rate. And so bottom line is adequate lung inflation, at least get the chest wall to rise. And we're going to show you in a second how we kind of looked at this even in other models. This is a ventilation model for moderate hemorrhage. And what happened was when we were giving breaths at only 12 breaths per minute, we were killing the animals, is what happened in a moderate hemorrhage. Or with the severe hemorrhage, even with a moderate hemorrhage where you wouldn't even be intubating the person. This is an animal model, and here you are giving the breaths, and you can see what it does to coronary perfusion pressure. These blue lines here are systolic and diastolic pressures, and the area under the curve, therefore, are pretty close to your coronary perfusion pressures. And you can see with each breath, we're knocking them down. So this goes along with the stuff. I think I took this picture in the laboratory years ago, but we did later get the data. We digitized it, and so you're going to get a better imagery of what happens here. So, for example, here we go. Let me just say, in this picture, is that if this is at a breathing rate of what I think this was like 12 breaths per minute, and we're really knocking it down. And what happens, we were getting much better blood pressures, much better flows when we went down to 6 breaths per minute. And so let me just show you another study where we looked at arterial lactate at baseline, at 40 minutes, and then a final lactate that we were getting with respiratory rates of 12, respiratory rate of 6, and end tidal CO2s. So this actually told us that we were doing pretty well, in terms of end tidal CO2 can help you guide this, as shown in this exemplary thing. So here we have brain tissue oxygenation. We were looking at Lycox, in the brains at this rate. And so here's your respiratory rate of 6, and it's actually almost normal blood flow during that period of time. Whereas at 12 breaths per minute, which everybody would think is normal, was that. And by the way, we're using here 10 mils per kilogram tidal volume in these animal models, all along. And here we go in terms of end tidal CO2 was not as good, but it came pretty close to helping us guide, what we had to do at that point in time. So it basically is probably we're fortunate to have that to help guide us nowadays, et cetera, in this situation. So, okay, so that seems logical, but does this work in real life, this whole approach here? And so one of the things I can say is that both in Houston and Seattle, where I worked, when we used these larger tidal volumes, much lower rates, proper delivery, we did intubate, in these patients, is that what we found was that endotracheal tubes normally correlate, obviously the sicker patient correlate with better, with more mortality. And paradoxically, we found that end tidal CO2 correlated with survival because we were better oxygenating, we were getting better blood flow during these periods of time, and we were very, very careful about not causing any other further harm with too much positive pressure ventilation, etc. And we took this also to kids. Someone came to me and said, we've had no survivors with kids. So Paul Banerjee down in Polk County said, what do we do to improve the outcomes? And one of the things I did is that, in contrast to the conventional wisdom that kids have, respiratory problems, we got to give them more oxygen. Again, not faster breathing, and you're now in a cardiac arrest state, so it's a whole different thing. You might have had a respiratory cause of your cardiac arrest, but if there's no blood flow, you got to be careful. So we did the same thing. We saw dramatic improvement in survival of kids when we gave them a large lung inflation and then just cut the rate back down to 1 breath every 10 seconds, 6 per minute. And so that was really extraordinary. We one electric breath, only once given every 10 seconds, given with a steady squeeze over about 1 second or so, allowing quick recoil with quick release. We actually gave the breath during the recoil phase, etc. And what was interesting is that in 2012, 2013, which reflected the previous several years, we are getting no survivors whatsoever. In 2014, we started this whole new approach with ventilation, quickly going right to an IO, not leaving the scene as they had done in the past. And then the next 2 years, what we did was we actually knew if it's a 1-year-old, we were going to give 0.1 milligrams of epinephrine. We knew if it was a 9-year-old, we'd be giving whatever, 0.3 or whatever it was. We were planning that ahead of time in the ambulance and had it ready to go. What happened is that we were able to get the epinephrine before, when they used to drag them off the scene and put them into the ambulance, at 16 minutes. And of course, nothing happened, as you heard from Corey Slovis. In contrast, though, we show when we got it down to about 7 minutes, and then later having all ready to go and put it on board, getting down to 5 minutes, we're seeing even better improvements. Again, these are soft data. This is just correlations. These are just observational things. But I think it makes sense as well to actually control your ventilation, give the epinephrine really early, and you're going to have better outcomes. So I can't prove about the individual things, but doing this, we improved outcomes for kids dramatically. We're now up to 30 to 40% going home neurologically intact. And that's been very cool to see that happen. Okay. All right. So keep in mind, as a final kind of comments, that things like auto PEEP in COPD patients, I'll even have lower rates because the lung is staying in an inflated state during that auto PEEP. But hypovolemia on the other end, particularly in the kids, and that's part of what we also did, we made sure the kids were getting hydrated because they're often going to cardiac arrest after respiratory problems, after sepsis or whatever. So we make sure they're hydrated as well. These things will make all this worse over that period of time. So remember, these effect modifiers exacerbate positive pressure ventilation even further, especially in kids and the elderly COPD or the asthmatic anaphylactic patient. All right. Therefore, quality ventilation has some very elemental considerations just for starters. And I could go on more and more about this today, but you need to have adequate lung inflation. Do you have that? Are you doing the appropriate rate where ventilation is matching the perfusion? If it's a very low state like cardiac arrest, got to be careful. Are you looking at inspiratory time? Are you looking at the release time? What's the timing during chest compressions? Are you giving the breath during the recoil phase? Are there adjustments over time as flow increases, particularly if we're giving things like ITD and ACD or head up elevations? Are we getting better flows? And do you need to adjust for flow adjuncts, as we just talked about, whether it's using a mechanical device or some of the things I just mentioned? Is there PEEP on board, auto PEEP, volume status? All those things have to be considered. I can go on, but these at least give you some insights to all this. And remember, you can't have high performance CPR and blood flow through the lungs without high performance ventilation. Okay. There's one disadvantage for providing these physiologically sound practices. And there you go. Pearly Gates, St. Peter, and saying, I'm afraid you'll have to go back. They're resuscitating you with quality ventilation down there. So with that, on the road to the 22nd century, I hope that we'll get back people we never got back before, and we'll make life better for future generations. I'm Paul Pepe, and I approve this message. Thank you very much. And I guess we'll take questions later, correct?
That's correct, Paul. My thanks to Dr. Pepe. We can all take a deep breath at this moment. Just kidding. Dr. Pepe, thanks so much.
Couldn't hear you.
I would summarize what I know of Dr. Pepe's career is that he is always at the cutting edge of what the rest of us are going to be learning about cardiac arrest. And I can see it from some of our folks that we are getting a bunch of questions that we're going to be sharing with you at the panel discussion. So don't go too far. Now.